سوري اخ حيدر راح الشير.
هسه دكتور ابدي. اي تمام.
هنا اوكي. المحاضرة بعنوان Implant Retained Fixed Prosthesis to Cement or Screw. It's based on a literature review that we did about the implant retained prosthesis, the fixed prosthesis in particular, to cement or screw اللي هو age old question. فراح ابدي شوية بالباك جراوند عني وبعدين about what's the literature review, and then we'll present some cases afterwards and see if you have any questions. I'm Nibras Alnaimi. I work in 2 practices in the UK. One of them is Dental. I started back in 2007 in this one. I provide general dentistry and implant, and it's in the middle of United Kingdom. It's in Nottinghamshire. صار لي هناك اشتغل من 2007. والعيادة الثانية اللي اشتغل بها بارت تايم اسمها Stepwise Dental Practice اللي همنا اشتغل بها من 2010 إلى هسه. وهاي من العيادة الثانية في منطقة داربي همين بإنجلند، قريبة همين عن نوتنغهام، يعني مثلهم in the middle of England. هذا التيم مالتنا. هاي العيادة Stepwise أكثرها هي specialist center. So الدكاترة اللي ورا هذول كلهم specialists والستاف هذا هذا فرونت. شهاداتي BDS من بغداد سنة 2000. Member of Faculty of Dental Surgery of the Royal College of Surgeons of England. Magister or Masters in Implantology من Cardiff University و Certificate in Restorative Dentistry من Cardiff University. So at training for conscious sedation من Newcastle University, member of SAD. Invisalign provider since 2009. Another master's degree in restorative dentistry in Birmingham University or University of Birmingham, or associate fellow in the College of General Dentistry, really a part of the Royal College. راح نبدي هسه. This is my background. This is the degrees and the courses that I've done. What is cement retained implant fixed prosthesis? So the implant fixed prosthesis is basically you have the implant, an abutment, and you treat it just like as a normal crown, where you put a crown on top and it's cement retained. So this can be removed, or like it's separate to the implant, it's not connected directly to the implant. It is just like treating it as a normal crown. The screw retained implant prosthesis is when you have the crown and the abutment as one unit and it's screwed directly into the implant. So this one is as one unit screwed in, and then you close the access hole. So these are the 2 different types. Of course, this is single crowns, but they come as in multiple versions as a bridge, full arch prosthesis, and so on. فهسه شوية boring part اللي هو طبعا literature review. It's boring, but so what? This is the informative part. So multiple systemic reviews have been done on the individual type of fixed prosthesis, but there is very, 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 very limited amount of studies that have compared both of them together in the sense of screw retained and cement retained at in the same study. From the ones that we found in Cochrane Review, Cochrane Library, and in PubMed was only 4 randomized controlled clinical trials. I'm talking about clinical trials, not lab trials or anything like that on human. So only 4 randomized controlled trials found in Cochrane Library and PubMed. In addition, we found by manual search to another 3 trials that has been found to meet the criteria. So those 7 clinical trials meet the inclusion criteria اللي we set it up. اللي هي at least there is 1 year follow-up, and the design, it should be randomized, controlled, but they are trials. 3 had a split mouth study design. Split mouth, that means they do implant on the left-hand side, right-hand side, but one of them they put screw retained, the other one they put cement retained. 3 studies have single restorations, and there are many other studies that have fixed partial prosthesis, which is bridge, and there's a complete arch prosthesis. Those 7 studies we found they have 787 implants between them, 223 participants. Well, as I said, the follow-up minimum is 1 year, and some of them had 15-year follow-up. Unfortunately, we couldn't find many studies that have the same type of implant. So the implant basically is different in each study. So screw retained implant, fixed implant prostheses. What's the benefits on them? Or what are they? These are the first ones that have been used when they started with the dental implant by Brenner Mark. He's the one who reintroduced the implantology dental implant into the dental field. It's have better and more predictable retrievability, which is the main issue. Retrievability meaning that you can put it, take it out, inspect it, put it back again without any damage. So that's what retrievability is. The screw access opening, this is the downside about it because it may affect the occlusion contact. And it can cause weakening of the porcelain. The screw access hole also may pose aesthetic issue if it is in a very visible site. It requires a more precise implant placement. So if the implant, although this has changed, which I'll come about it later on, but if the implant is placed too much angulation or too much buccally, that means the access hole will have to be on the labial or buccal surface. It may pose a problem. The components have higher cost compared to the cement retained because the whole thing has to be one unit. So it needs to be treated as such, and you need to get the proper components for it. So even the lab fees are higher. Maybe consider advantages in using cantilever design. So if you have a space of 2 teeth and you want to use only 1 implant and cantilever the pontic, then obviously screw retained is the one to go for because cement retained can have higher decementation. It can be used where there is a limited vertical interocclusal space. So if the patient have very limited space because the opposite tooth have over-erupted, for example, you cannot put cement retained very easily because you have the abutment separately and then the crown separately. So you need more space. While the cement retained, because it's 1 unit, it's considered that it can be placed in limited interocclusal space. Some studies suggest that screw retained have higher tendency to fracture of screw or abutment. This varied from one study to another. Some studies never mentioned that there is any difference between screw retained and cement retained. Some of them, no, they have stated that there is some differences. The cement retained, now we're going to talk about more about the cement retained implant prostheses. They are the most often used to date. The difference between the screw retained, we said it was the oldest one. This is the more used because, as I said, it's considered cheaper and it has other benefits. Poses a risk of complete fracture when you try to retrieve it. So the problem with retrieving it, it can be because when you try to retrieve it and remove it, if the cement is too strong, then it will break. It will just basically crack. So that's why it poses a problem if you have loose abutment or something like that. Sorry. Okay. It can be used in high aesthetic area. Sorry, before that, it can correct and compensate for different placement angulation. This is what I was talking about. If it was placed buccally, then because you can get the abutment to correct the angulation, and then you can get the crown on it, which correct this issue. The other way, it can be used in high aesthetic demand areas because it's like a crown, covers all the visible area. it has no weak porcelain autoocclusal plane. So for in screw retained, you have the access hole, which may poses, if it's not done properly by the lab, it may poses a problem because this area will be weaker. It will provide an easy access to posterior region. So for example, lower 7, upper 7, where if you want to place the screw retained, sometimes you don't have a very short screw, the driver for torquing it. So this may pose a better advantage. The components are cheaper because you can get any stock abutment and take an impression of it and use it as a normal crown. The lab can make it for you. It provides an advantage of being passive engagement with the implant. So what that means is because you are not torquing the crown and the abutment together, you are torquing only the abutment, and then the crown can sit passively. So the pressure is not transmitted directly into the implant itself, especially in multiple implant restorations, which has advantages and disadvantages as always. And if it's again posterior tooth, like upper 7, lower 7 area, then the problem with it is when you want to cement it, you have to remove all the excess cement. And this sometimes in limited mouth opening can cause problems. Okay, the biological risk associated with excess cement is an issue if you leave it, because it can lead to peri-implantitis and perinucleositis, and poses a risk of decementation. So these are the advantages and disadvantages of the screw retained and the cement retained. Now, which one to use, screw or cement? Some studies have suggested this is called the tree of decision, or decision tree, which I will break it down into different sections. But basically, this helps you in deciding whether you want to screw or to cement. But there is exceptions, obviously, which I will come about. And also, this is slightly old because there is no recent studies. In the past 5-6 years, there is magic happen, which is called the angle screw, the angled correction screws, which can correct the angulation of the crowns, which again, I'll talk about it in a minute. So for anterior implants, the main thing that we have to consider is, from placement point of view, is how the implant is placed. Is it placed in an ideal situation or ideal position? That means the access hole is palatally, if it's upper or lower, or if it's angled, which means it's mal-positioned. In restorative point of view, it's not mal-positioned that the surgeon have done something wrong, but he just followed the availability of bone. But if it's mal-positioned from restoration point of view, that means the access hole is more buccally. So we have the bone level implants or the soft tissue level implants. It doesn't matter. The main thing is about the implant position. Just to go back a bit, bone level implant, that means the neck of the implant finishes at the bone level crest. Soft tissue level implant, that means the implant may extend into the soft tissue, which is, I mean, we can call it the gingiva, but it's not really, it's just the soft tissue. So is it a good positioning? Then you can use, or highly recommended to use, screw retain. This mal-positioned, as we said, then it's cement retained because you are correcting it. But as I said, again, wait for me a bit, because later on we'll talk about the angle screw correction. So this is a patient. She had a problem with the upper left one, where, well, it's very bad root canal treatment, but it's been like that, believe it or not, for 15 years. There's a cyst apically. So we, and when she presented, there was a crack on the upper left one. So we extracted the upper left one, we did an implant. This picture is with the healing abutment. And that's the Straumann tapered BLX implant. BLT implant. That's placed in there. And this is the implant crown place, and also we replace the crown on the upper right one. So this is a direct screw one crown, which you can see the crown one unit into the implant. And that's the final results. So the one on the left is pre-op and on the right is post-op. Same thing, again, she had an accident, fell 2 teeth out, 2 implants placed. Those are the implants, and these are the screw retained because the implants were placed in a perfect position, as you can see. So the access hole of the implants are placed palatally. This is a bit of multiple approach. So this patient have multiple issues, wearing a partial denture, lost more teeth, gum recession, not happy with the teeth, multiple gaps. So the treatment option was 2 implants on the upper left 2-3 area, and bridges and veneers for the upper arch. So upper left 2-3 implants, and we decided to do a bridge, upper 4 to 6, upper right 4 to 6, and veneers on the remaining anterior teeth. 3D printed model, because we take digital impression. I mean, up till 3 years ago, it was still impression, pattern wash, and so on, but now I'm purely digital impressions. So this digital impression with multiple different units, that's the bridge on the upper left 4, 5, 6, implants on the upper left 2, 3, veneers on the centrals, upper right 2, 3, and bridge again on the upper right 4, 5, 6. And this is all the restorations fitted. So that is the post-op. As for the posterior implants, so we spoke about the anterior implants area. As for the posterior implant, again, we go back to the same principle, which is implant position. Now, there is again, good position. That means the access hole or the emergence of the implant is in a central occlusal area. So you can have screw retained. If it's mal positioned, then again, you can think about cement retained. But again, the game changer happened when the angle screw up, angle correction screws came into light, and this have changed a bit. So this is when it was the old time when I used to take an impression, single implant, upper right 6. That's on the model, screw retained, the healing abutment in the mouth, and that is the fitted crown.
سوي علاقة له سوي. والعلاقة له خلي لي هنا من الباب، اشيله وياه باشر زته بالحاوية، أنا وطالع. يعني هذه تسويها اليوم.
اخوان بس تدون المايكات اذا بصير زحمة.
This is another case. This one is Nobel external hex implants. So again, that's at the impression time. This is the pickup impressions for open tray. And these are the crowns fitted. Again, that's a screw, because you can see where the access hole is from the center of the occlusion. Now, we come to the exceptions where we can or cannot use one over the other. So for the posterior implants, if the implant position is good positioning, but the occlusal surface, intact occlusal surface is needed. So when I mean intact, so if we go back to this case, So because this is a wide teeth, then it's fine. You can see the size of the access hole. But if you need a narrow teeth and there's not enough space for the access hole, then we maybe change to use a cement retained rather than screw retained, because with the cement retained you can make it narrower compared to the screw retained. The other exceptions is anterior posterior implant, but as I said, inadequate interocclusal space. So it needs at least 4 millimeter of interocclusal space to accommodate for all the screw and the ceramic that is there. The screw retained in that situation will work because the cement retained, there is not enough availability for it. So there is some other studies that have reviewed and formulated a list of indications that prefer one type of the other. And the indication that suggests that screw retained may be better than cement retained, as we said, full arch, long spans. So the reason why screw retained is a bit better in here is because you will need to remove it and put it back more often. And as we said before, cement retained is not easy to be removed and placed back without any damages. Cantilever design, as we said earlier, because you can cantilever from one implant to two ponticum retainer, but with cement retained, it will be higher possibility for decementation. High risk of developing gingival recession patients. So if it's a thin biotype, then the cement retained may be contraindicated because it can cause to gum recession. And as I said, limited interocclusal space, as we said earlier, and there's a high risk of losing more teeth adjacent to the implant. And this go back to the cantilever design, or if you want to put another implant and do a bridge later on. So again, because you can retrieve it, you can remove it and put a new one in there, a new crown. So screw retained is better in that aspect because of removal and placing back. Cases where it's difficult to access and remove the excess cement if cement retained restoration was to be used. So as I said, in posterior teeth or limited mouth opening, and cases where there may be need for continuous adjustment. So patients may have bruxism or clenching or grinding, where there may be a need to remove it, adjust it, send it to the lab a lot more. So that is where the screw retained will be better indicated. As for where the areas that cement retained is better, is when the case is a single unit or short span, then it's not better, but it can be indicated. There is a need to have a narrow crown, as I said, for one reason or another. So it does not allow for good size of screw access hole. High aesthetic demand, where patients does not wish to see any access holes, even though that we are filling it with composite or whatever, but they have a wide smile, certain demands. They need to correct the long axis, as we said, but as I said, again, limits of the angle correction screw beyond that, which I'll talk about it in a minute. And the access, if the access hole compromises the strength of the substructure, because that means, again, it's a small tooth, very small tooth or narrow tooth, that the access hole is too big when it happens. So this the areas where cement retained may be more favorable to screw retained. Now, this is the game changer, which is the angle screw, because angle screw, when they arrived, they allowed us to change the angulation at which we can get the access hole. So the angle screw basically means that the screw itself does not need a direct access. It can go up to 25 degrees of angulation. And as you can see in these images, if this implant, for example, wanted to have a straight direct access, the access hole will be directed at the buccal surface, which will affect all the aesthetic. While on the other image, no, you can see that you are accessing it at an angle, which can reduce the issue and can make us use a screw retained. Again, this is another one, because it's like a rose head, the driver for the screws. And all companies do it now, Straumann, Nobel Biocare, or AstraTech. So this case, which is upper full arch, and we managed to use all screw retained because of the angle correction screw. So this patient presented with multiple failing bridges, and these bridges, there was a fractures in the anterior bridge, the one from upper right 2 to upper left 2. So we've extracted that bridge. It had the post crowns and there was cracks in the roots. Then we spoke about the prognosis and longevity of the other teeth in the upper arch because of the gum recession and because of bone loss that's happening and the prognosis of these teeth. The patient agreed to remove all the remaining upper teeth and continue on having upper full arch. So we did it all on 6. These are Straumann implants. The posterior upper left and the upper left 3 and upper right 2, they are NC, and the upper left 4, 5, upper right 4, 6, they are RC. And these are the implants after the healing. And there's the digital impression. So I do, as I said, mainly now scans. So we put the scan buddies, we do the scan to the area, send it to the lab digitally. And these are the scan buddies that we use. Obviously, it depends on the size, on the make, on the model. So each one has its own scan buddy. Then I know that the digital is highly accurate, but with these things, you cannot allow for any mistakes. So I still do a verification jig with temporary abutments. So the lab do Duralay temporary jig model. And also that temporary jig can help in putting, which I'll show you in other cases, how to measure the vertical occlusal height, do a wax rim, just like complete dentures. And this is the actual bridge. This is not an acrylic bridge. That's a pure ceramic with pink ceramic. This is mounted on the 3D model. And you can see the gold screws in the access hole. These gold screws are the angle correction screws. And as you can see, all the 6 implant abutments, and that's fitted. And this is where is the access hole. Okay. Sorry, I don't know what happened. Give me 2 seconds. Yep. And this is at 6 months review. Unfortunately, I should have asked her to have scan and polish before the photos because of the all the staining on the lower teeth. And this is all the bridge fitted. I said it's at 6 months. And the bridge.
رجاليا
This is another case. So that case is done. This is another case where it's all on 5. So again, this is the verification jig on the 3D model in the patient mouth. And this is the metal try stage. And again, this is the bridge. And again, that's all porcelain with pink porcelain. We are doing the lower arch for her at the moment. Doing again all on 4 for the lower arch. This is the pre-op because she had other teeth. She already had 3 implants. Then we added 2 because all the other bridges has failed. And then this is the before pre-op, and that's the post-op. There is another solution if in case you want to do a screw retained bridge or crowns, but the angulation is more than 25 degrees. As we said, the angle screw can help you up to 25 degrees. But the other solution that you can have is multi-unit abutments. Now, the multi-unit abutments, there is also screw multi-unit abutments. So the way it works, that it's like double screw. So you have the screw, initial screw that you can see that goes into the implant. And then it has many different angulation. There's straight, there's angled. And then you screw your bridge or the fixed prosthesis into it at an angle. So this will be like a double screw. So this patient had this bridge for, I think, if I remember correctly, it was 15 years. Because the practice I work in, they've been doing implants since 1992. And this was one of the early cases that they did. So the upper arch full bridge, but this is the acrylic one. And the acrylic is breaking and fracturing. So it's reached the stage where we'll have to replace it. 8 implants in there. They are Nobel BioCare tri-channel implants. Again, verification jig. And this is the the wax bite. As I said, this is where we check the occlusal vertical height, the central lines, the canine lines, and send it to the lab. So this is here all the abutments that are there, and there are many different types. So the gold on the left-hand side, but it is the upper right 5-6. These are tri-channel, these are directly into the implant. And the blue on the left-hand side of the upper left 6, that's again, direct screw. Then you have the other ones which have like a hexagon that's coming out of the implant. These are multi-unit, but they are straight multi-units. So the one on the upper left 4-5 and upper right 4, these are straight multi-units. And the one looks like a dome, this is the angled multi-unit. So you can see the screw in the middle is the screw into the implant, and the one on the side is where we're going to screw into it. This is the metal frame try. The reason why I try a lot, especially with full arches, because there is no margin for error. If there is any strong torque, if there is 1 degree mistake, it will cause multiple issues and failures. And this is the finished product. Again, full porcelain with pink porcelain. And this is fitted in the patient's mouth. Another case for multi unit abutments. Again, this is a very, very old bridge, acrylic type, but it's a fixed bridge. Again, you can see the multi-units in there. So again, the screw inside is the one that's screwing into the implant, and then the cone is the angle corrections. And this is the new bridge fitted on the upper arch. This is one of the bigger cases because this has multiple upper and lower multi-unit abutments and implants. So again, this is over 20 years old. He had it, and again, you can see it was acrylic, all breaking down, worn. So this is the impression pickups, open tray for the upper arch. And this is the jig to fit the multi-units, the angulation. So we have 2 straight and 2 angled. And this is the all-on-4 porcelain bridge, fixed prosthesis. And that is that fitted. We did a shortened dental arch because there is no massive space posteriorly. And then afterwards, we started working on the lower arch. So we started replacing the lower arch. Sorry, I just need. And this is the lower arch, 6 implants. If you look at the X-ray, this patient was had those lower implants by a max-fax maxillofacial surgeon who placed some hip bone into the lower mandible. So although it looks like it's sticking out of the bottom of the chin, but no, this is a hip bone in there, and there are 6 implants in the lower arch. Now, again, there's something else you need to notice. These are novel biocare with straight multi-unit abutment. So these are not actually any bone loss to them. There's the upper arch that we fitted earlier, and this is the lower arch that we need to replace. So these are not bone loss. These straight multi-unit abutment. So you have a fixture, but then you have a straight sleeve and a multi-unit. So all what you can see is the multi-unit abutment rather than the implant itself. There is no bone loss around the implant itself. Again, open tray pickup. As I said, this is a bit of this was done about 6 or 7 years ago that I've done it. So it's at the time when I used to do a normal impression. And there's the verification jig. That's the wax, again, for the vertical height. Unfortunately, digital impressions don't get this step correctly, so we still have to go a bit old school by doing the vertical height. And this is the bridge, but because there are multiple opening, we did in bio-HHP. So we did also like a cover for it from porcelain. And this is the bridges fitted. So as you've seen, I rarely do any cement retained, but the main thing about if you can get away with screw retained, it's all about retrievability, because that means you can remove it and put it back again and again and again without problems. If there's any mobility, if it needs tightening up, there's loose, you need to check if the implant is okay or not. That's all can be done with screw retained without any problems. With cement retained, no, you cannot do that. If you want to remove it, that's it. You have to most probably break it, or also there is the issue with the excess cement. So personally, because as I said, the practices that I've been working in, they've been doing implants since 1992. So I've seen a lot of old treatments, a lot, in the sense they come and we need to replace things for them, or they broke, or they cracked, or they lost the other tooth, or they had, as you see in one of the cases, they lost the teeth adjacent, and we want to use that implant for a bridge, but we still need time to take impression, to get it from the lab. You cannot just leave it open or put healing abutment. So retrievability is the key issue here within the implant treatments. And obviously longevity, because again, longevity is all connected to, can you remove it and fix it? The two major issues that reported, as we said, in relation to screw retained is possibly ceramic fracture because of the excess hole, or screw fracture, which can happen in cement or screw retained. But again, even if the screw fracture, it's easy. You can remove this broken fractured part of the screw and put a new screw. If it's a ceramic fracture, again, in my opinion, it's easy. You remove it, put healing abutment, send it to the lab. They remove the ceramic, put a new ceramic on the same abutment and send it back. While the screw retained, you always have to remove it, crack it. And this is where the issue for me. So I hope you'll find this information helpful. If you have any question, please don't hesitate to email me. And there is also the list of references in there if you're interested. So,
اوكي دكتور، عاشت ايدك، محاضرة جدا قيمة ان شاء الله.
اهلا ومرحبا.
نستقبل الاسئلة اذا اكو من المشاركين، الدكتور جاهز يجاوبكم ان شاء الله.
السلام عليكم.
عليكم
شكرا
السلام.
جزيلا دكتور نبراس على المحاضرة الحلوة.
اهلا ومرحبا.
بس سؤالي على الانجل سكرو.
نعم.
أنا اللي أعرفه أنه هي أول شركة يمكن بدأت به هي شركة نياس، بس الآن هل هو متوفر على مثلا أي زرعة، أي قاعدة، أي سيستم، ولا راح يكون محدود؟
أنا أحكي لك على اللي أنا أستخدمه. أنا أستخدم نوبل، مثل ما شفت نوبل بايو كير وأستراتيك وستراومان. طبعا ستراومان اللي هو نيو دنت من ضمنها، كلهم بيهم أنجل سكروز. كلهم هسه حاليا احنا ببريطانيا هنا عندنا موجود كلها انجل سكروز up to 25 degree angulation. فما اعرف بالنسبه للبقيه، بس انا حسب علمي يعني نحكيها بصراحه، من شركه واحده تسوي فد شيء الكل they copy it. فمتاكد انه كل الزرعات البقيه موجوده، بس لازم تسال عليها، يعني انه لانه حتى الدرايفر مو نفس الدرايفر مال ستراومان او مال العادي مال ستراومان او مال استراتيك او مال نوبل، لانه يكون راس الدرايفر مثل روزهيد، يعني مثل طوبه وبيها حزوز على مود تقدر تفوت له انجوليشن. بس انا ما اجاني اي امبلانت الى حد هسه، يعني خلال هاي ال4-5 سنوات اللي فاتت. حتى الامبلانتس مو بس اللي انا مسويها، انا يجوني هواي انه مسوي بغير اماكن، طبعا حسب الماركات الموجوده ببريطانيا. احنا ما نقدر مثلا، يعني احكي بصراحه احنا نعاني مرات من يجونا مرضى من حتى من مرات من تركيا او من العراق، من الامارات، مسوين زرعات. اكو مشكله انه اول شيء ما نعرف شو نوعيه الزرعه، ثانيا حتى اذا موجوده او عرفوا شو النوعيه، اذا ما عندهم وكيل او ما مسموح بها ببريطانيا، احنا ما نقدر نحصل الكومبوننت مالتها. فانا احكي لك عن الموجوده عندنا، كلها بيها انجل سكرو كوركشنز، بس وهاي حسب يعني انا من خبرتي بالاشياء اللي انا استخدمها، بس البقيه ما اعرف. يعني النوعيات الثانيه الكوريه او التركيه، بس مثل ما قلت لك هي كلها واحد ياخذ من الاخ، فاعتقد راح تكون نفس الشيء.
تمام، شكرا دكتور. زين، السؤال الثاني ولو
دلع.
طول.
لا تفضل.
أنا شفت بعض الحالات أنت قلت أنه يعني الزرعات مختلفة المناشئ ومختلفة الشركات. هل تعتقد أنه يأثر إذا مثلا أنا حطيت مثلا 5 زرعات، زرعتين من شركة و3 زرعات من شركة ثانية، هل يأثر على نجاح الحالة بالمستقبل ولا ما راح يفرق؟
100% يأثر. أنا كل الحالات اللي رويتك إياها ولا واحد بيهم من شركات مختلفة. الهيدز كانوا مختلفات، لأنه واحد حاطين له مالتي يونت، واحد ما حاطين له مالتي يونت، والألوان اللي شفتها نفس الشركة مرات بيها حسب الدايمتر، مثل الانسيا وارسي هاي اللي قلتها على ستراومان، هاي نارو كونكشن او ريجولار كونكشن، بس هي كلها ستراومان. فاحنا دائما نحاول نبقي الكيس من نفس الشركه. يعني مثل ما قلت عندنا هاي الحاله اللي همين روتك اياها، وهي كان عندها 3 امبلانت 3 وبعدين ضفنا لها 2. هاي كان عندها استراتك، الا جبنا لها استراتك وخلينا لها اياه، لان ياثر، لان تعرف مثل ما تعرف حضرتك كل شركه الريكومندد تورك يختلف وحده عن الاخ. فانت ما يصير تجيب نوعيات مختلفه وتخليها، يعني كان شركات مختلفه مو من نفس الشركه، لان هاي بس النارو بلاتفورم او الكونكشن. بس تجيب كل شركه شكل. ستراومان مثلا 25 نيوتن سنتيمتر يخلون، عسرة يريدون 30 نيوتن سنتيمتر التورك مالتها. فانت من تجي تخلي ديفرنت تورك على كل امبلانت شكل، خصوصا بالفول ارش، هذا ياثر بعدين لانه راح يصير روكينج موفمنت. فنصيحتي انه لا، لازم دائما، طبعا اذا ما تقدر بس حاول دونت كونكت. يعني مرات يجونا بيشنت مثل ما قلت لك، مرضى مسوين زرعه بتركيا او بالامارات او حتى يمنا باسبانيا مثلا، او باماكن دار مدارنا، او حتى امريكا. نقول لهم هذا الامبلانت احنا ما نتعامل به. ليش ما نتعامل به؟ يا اما موجود يا اما ما نعرفه، ولو احنا ايديال نقدر نسوي بريدج وياه بس ما راح نقدر نستخدمه. فنعوفه ذاك الامبلانت نطخه ونسوي واحد يمه. جت عندنا حاله حتى انه الامبلانت وي كفرد ات، يعني بس خلينا الكفر سكرو اند وي باريد ات، واستخدمنا فوقه، لانه احنا بالنسبه لنا تحمل المسؤوليه عندنا مشكله. ذا مينت احنا نسموها يو تاتش ات يو اون ات. يعني انا اذا الامبلانت مو انا مسويه وما متاكد من مالت يعني النوعيه او الصناعه، او بعدين اجي اتعامل به او اسوي عليه كراون، صار مسؤوليتي. ما اقدر بعدين اجي اقول لا والله مو انا سويت الزرعه، مو مسؤوليتي. احنا قانوننا ما يشتغل هيك، قانوننا يشتغل ما دام انت تعاملت به وطخيته صار مشكلتك. فهاي المشكله اللي عندنا بيها. فقانونيات شويه يعني مو اقول لك هي مزعجه، هي صحيحه القانونيات، بس يعني هنا وهم يعني طبعا بيها فائده، بس احنا تعودنا على هالشيء. فما اعرف انتم يعني طبعا اذا تعرف الماركه وتعرف انه هي راح تشتغل فخلاص انت على راحتك. بس احنا هنا انا ما اخلط عن نفسي.
ألف شكر، جوابك جدا واضح جدا جميل. ألف شكر على
تدلع. اذا اكو سؤال لا ما اعتقد. عفو معالي السيد حيدر.
ما أعتقد بعد أكو سؤال دكتور.
نعم.
أي جدا نشكر حضرتك دكتور،
دلع.
ومجهودك إن شاء الله يعني إحنا نقدره ونثمنه. محاضرتك جدا قيمة، وإن شاء الله يعني نلتقي بمحاضرات أخرى في الأسابيع
ان شاء
الجاية.
الله. ان شاء الله. ان
ممنونين
شاء الله.
حضرتك دكتور، شكرا جزيلا.
هلا مرحبا. مع السلامه.
شباب إذا ما عندكم فشي راح ننهي المحاضرة.
مع السلامه.
تصبحون على خير عيني، مع السلامة.
مع السلامه.
مع السلامة.